all have this knowledge, but we're just going to refresh it on the adverse effects of immunisation. We also are going to look at the pathophysiology of anaphylaxis and anaphylactic shock. It is really the one you don't want, but it's also the one that you kind of need to be ready for because it happens so quickly. We're hoping that we will increase your confidence in the early recognition of anaphylaxis and consolidate your knowledge in the management of anaphylaxis.
So the session content for this evening, we're going to be looking at immunity and immunisation basics. What is a vaccine allergy? Immediate type 1 hypersensitivity reaction, which really varies from the rashes to right through to anaphylaxis. Our APHIS, we're going to have a little Zoom room activity towards the end.
Which, you know, we're all a little bit new at that, so
we'll do our very best.
That's our disclaimer for that one, for Alicia and us.
We'll be have a really good look at anaphylaxis. So we're going to define it, look at the patho, some early recognitions, and our signs and symptoms. Some of them can be really subtle. How do we manage it? Looking at adrenaline. It's something we're all scared of, but it's something that's so important. And anaphylactic shock.
Yeah, if we miss it, where we head, pretty much. Okay, so immunity basics. So as we all know, the immune system is the body's ability to protect and prevent invasion of pathogens. Okay, it's made up of lots of different parts of the body. So you've got your white blood cells, you've got your antibodies, your complement system, your lungs, your thymus gland, your bone marrow, and your spleen, and also of course your skin, which is a great barrier when it comes to protecting us and giving us immunity. Go, Steph.
So the immune system recognises antigens, so the bacteria, the viruses, the toxins that we're exposed to. Those little antibodies then mark that antigen for destruction. So the immune system actually helps to protect the body against the infection. It's designed to identify and destroy those harmful foreign organisms or pathogens from the body and neutralise the toxins that some of those bacteria actually produce. So they do that, the immune system does that by developing these T cells and B cells. They keep a record of the microbes they've defeated along the way. So next time they can actually, when we're exposed to it, they recognise it and they destroy the microbe as quickly as possible. And that job is the destruction of the phagocytes and the chemicals, when we'll talk a little bit more about them.
We probably all remember the phagocytes from when we did bioscience and biology when we started our nursing. They're those little Pac-Men that run around and basically gobble things up. So, okay. Oh, and there's a little picture down there. We will be sharing our slides to you guys later as well. But this just shows the organs of the immune system, that little picture down in the bottom right-hand corner. All right, the responses that we have. We've got a cell-mediated response and we've got a humoral response, okay? So the cell-mediated response, that involves the T cells, and they all have specific roles. So they can be killer cells, they can be helper cells, they can be memory cells. So, and it is just as it says. They either kill the antigen, they ask for help from the B cells to produce more antibodies so that they can actually help with the destruction. Or they've got the memory cells. So the memory cells lock in what pathogen they've come up against, which is, exactly what our vaccinations do. They lock in, yes, and then the next time they have a response, it's much faster and it's much more aggressive. The humoral response, that's a quick response. And that's against the pathogens that are in the extracellular space. And they're the ones that are trying to invade the host. The antibodies are produced by your B cells, and then again, they're marking the antigens and they are destroyed.
So the B cells, they actually produce the antibodies. So they're known as immunoglobulins. We've all heard of them. They've got IgMs, IgGs, IgAs, IgDs even, and we've got the IgEs. And the IgEs are the ones that we'll be concentrating on today because they are the ones that are responsible for our allergic reactions that we get.
They are. Okay, so the two immune systems that we all, I'm sure, remember are the innate system and the acquired and the adaptive. The acquired and the adaptive are the same system. They are just interchanged. In all the research, some of it you'll read it's acquired and some of it you will read that it's adaptive. So just remember that they are the same. So the innate immune system is, as it sounds, it is an inherited immune system that basically we're born with it. And the children, they recognise invaders and there is an immediate reaction. So again, we've got an engulfing of the invader by the macrophages or the phagocytes. The acquired or adaptive immune system, that immune system produces the antibodies to protect from specific invaders. Okay, so as we've said before, and we'll say it a couple of times, those antibodies are produced by your B cells as opposed to your T cells after exposure to the invader. So that can take days to develop and it can change throughout a person's life. So of course, you know, as you know, if you have an immunisation, it can then go on and take some time for all those antibodies to actually be produced.
So then, you know, just press a little mouse for me. Thank you. We've got our primary immune response, which is our very first exposure. That's where our memory cells that we talked about in the slide before will actually remember the pathogens for life, resulting in the priming of the immune system with the antibodies. So those little IgEs. We've got a great pic coming up that explains how that process works shortly. And then you've got your secondary immune response. So that is the much faster and it's far more effective. And again, we'll go on to that in a minute.
Oh, there we go. We've got a little picture down there that you can have a look at later when you've got the slides. So immunisation, what happens? There's two ways of acquiring immunity to a pathogen. So one is a natural infection, which speaks for itself, and the other one is immunisation or vaccination, of course, which mimics your natural infection. The end result is quite similar, but the person who receives the vaccination, as we all know, does not endure the illness and the potentially life-threatening complications that can go with it. Okay, so they're the two ways. So as we all know as well, vaccines just give a small amount of the antigen and then the body builds up via the B cells. It starts to build up those antibodies.
So everybody loves a little bit of data. So here we go. So PHN, our most recently quarter data for Gippsland, is looking pretty special. We're at 95.92% of all of Gippsland kids under 5 years being fully vaccinated. And you look at the states average, 95.75, and Australia, 94.77. So in our little neck of the woods, we're doing really well.
We are indeed. That's you guys that are doing really well. 1 second, I've just got to close that off. All right, so now on to what we're really here for. What is a vaccine allergy? Similar to other drugs, like we all know, we're nurses, so all drugs can cause allergies in different people. They can have different allergic reactions. So almost all vaccine components can be considered as potential triggers for allergic reaction. I'm just going to read them out here. So we have proteins such as your egg and your gelatin are often implicated, but so are the other components such as the preservatives, the adjuvants, which is the word that I was worried I wouldn't be able to say, such as aluminium salts. They've got stabilizers, being sugars and gelatin. Formaldehyde is in our vaccinations, which is a residual inactivating ingredient. And then you've got some residual ABs, like neomycin is in there. So a vaccine allergy is actually a very rare type of allergy, but in circumstances it can be fatal. So that's why we want to be ready for the anaphylaxis.
So our little IgEs, as mentioned before, that they are involved in our allergies that we have under the type 1 hypersensitivity. So they're the ones that are stimulated.
That's all right.
Yeah. And I've lost my track. Hold on, guys. I'm coming back now. In IgE-mediated reactions, the primary allergens are proteins themselves. Anaphylaxis is a severe case of an allergic reaction.
Okay.
But we will discuss that.
We will. We'll go into anaphylaxis more. All good. All good. Okay. So there are 4 types of hypersensitivity reactions, but today we're only going to look at type 1. So type 1 hypersensitivity is an allergic reaction provoked by a re-exposure to a specific type of antigen, referred to obviously as an allergen. So it's something you're allergic to, whether that be a bee bite or a vaccination or a bull ant or whatever it is. So it's that sensitization. So it's also known as an immediate reaction. It involves, as we keep saying, the IgE, the immunoglobulin E. And this results from mast cell degranulation. So pretty much it results from the breaking down of the mast cells. Okay, and then what that does, it releases histamine. Sorry, I don't know if I'm looking at the camera. It releases histamine and other mediators that then go on to cause a cascade effect into anaphylaxis and allergy, or allergy first, and then potentially leading to anaphylaxis. So it occurs within minutes of immunisation, typically less than 60 minutes. As this says, exposure may be ingestion, inhalation, injection, or direct contact, like I said, and I've already said about the mast cells.
There's actually 2 stages in a type 1 hypersensitivity. So stage 1 is typically within that 15 minutes, but can take up to an hour. And this involves the histamine response. The second stage can develop over 4 to 12 hours post that first stage. And this involves activation of our neutrophils, eosinophils, and more mediators. And that's something to consider with the management of our patients who have had anaphylaxis before.
Absolutely.
So the mast cells, they're interesting. They're very interesting.
They're very cute.
So when they're behaving, they're doing really well. They're doing everything right. They regulate our vasodilation, vascular homeostasis, and they're involved in our innate and adaptive immune responses. However, when they're a bit stimulated and they're not behaving, they can degranulate, and then they're implicated in our allergies, our asthma, anaphylaxis, and GI disorders. In the respiratory tract, the immune response to mast cell activation results in airway constriction, we get increased mucus production, and we get a cough. So we've already got that actual response happening before we lead down the actual anaphylaxis process on pathway. And in the GIT tract, when we're exposed to an allergen, its response is to increase the fluid secretion, and also those smooth muscles get constricted and we get increased peristalsis. So that's where we see the likes of nausea and diarrhea and vomiting come through.
Okay, I hope you can all see this one really well. So this is how it happens. So you have your first exposure to an antigen. Okay, so that's called sensitization. So you can see, hopefully you can see my cursor there. So you've got the first exposure to the antigens and you get an IgE antibody production from your B cells. Okay, these then attach to your mast cells and your basophils. We haven't really talked much about basophils. We've sort of concentrated on mast cells, but they can be just as big a culprits as what the mast cells can. Then what happens is you've got a sensitized cell. So then you have a second exposure to the antigen. Okay, so let's pretend this is a bee bite. So you've got your first exposure and then your mast cells are now saturated with these IgE antibodies. The second exposure, the antigen comes along and then the IgE antibodies cause that, well, they attach to them and then they cause degranulation and release of these mediators. So hopefully you can all see how that happens. The IgE antibody here and the antigens attached to your IgE antibody there, then you get your breakdown here and degranulation and release of all those mediators. So Steph's going to talk about those now.
So there's actually 4 mediators. However, histamine is the main instigator and the main culprit in anaphylaxis. So histamine causes smooth muscle cell constriction. Your leukotrienes are potent smooth muscle constrictors. Prostaglandin constricts those bronchial tubes. And your cytokines, they stimulate inflammation. So what this picture actually shows is the capillaries. They're widening, causing increased blood flow. They're becoming more permeable, so more leaky. And then the leukocytes arrive. And as a result of all of this, you get some heat, you get redness, swelling, tenderness, and pain, which is your inflammatory response.
Okay, hypersensitivity symptoms. So allergy symptoms obviously vary from mild to severe. So your mild to moderate symptoms, you can have angioedema, you can have urticaria, hives, allergic reaction, non-urticarial rash. You can have some GIT issues with some nausea, some vomiting and diarrhea. And that's not necessarily anaphylaxis. That might be a mild to moderate allergic reaction, okay? And we're going to go into it obviously in a lot more depth, but it's when you move then into having some airway involvement and some cardiac involvement along with these that it becomes more severe. So this again is a result of our histamine. And so the rashes result from the histamine activity that goes on in the deep layers of the skin. And of course, the most severe reaction that you can have is your anaphylaxis. And it's estimated at just over 1.31, if I want to be exact, per million people will have an anaphylactic reaction to an allergen. So, you know, they are pretty rare. However, I've seen many.
So let's have a little look at our APHIS. So it's a negative reaction following a vaccination. Doesn't necessarily have to have any relation to that vaccine at all, and it can be classified as local, systemic, or allergic. Under recommended conditions, all vaccines used in our NIP are safe and effective if used correctly. However, in practice, we all know no vaccine is completely risk-free, and adverse events can actually occur after immunisation.
Absolutely. Okay, the common side effects to vaccinations include injection site reactions such as pain, itchiness, redness, swelling, burning, and injection site nodules. So if they are if they're a minor side effect and it doesn't affect the family coming back for future immunisations, and of course it doesn't go into something that's life-threatening, then, you know, for pain and itchiness and redness, you don't have to report it. But you do really have to think about reporting it if they're a little bit more serious, especially if it changes the family's thoughts about coming back again.
And an APHIS is considered to be serious if it results in death, clearly, is life-threatening, or requires any sort of inpatient hospitalisation, or it actually results in persistent or significant disability or incapacity. That's
pretty serious, I'd say, most of those. Yeah. Okay, we'll move on to potential APHIS.
So we're just going to touch briefly on our ones that we probably know more commonly. The list is quite extensive, but we'll just touch on these guys. So febrile convulsions. It's a response to a fever of any cause in children, quite commonly under 3 years. Brachial neuritis results in the weakness or numbness in the arm due to inflammation of those nerves. Intussusception. So it's when that bowel telescopes in on itself, it cuts off blood supply to that affected part of the bowel. You're going to know that your child has intussusception. They are very distressed, and it's actually treated as a medical emergency.
They'll be screaming with pain.
So HHE, or hypertonic hyporesponsive episode, onset between 1 and 40 hours, so quite a lengthy time there, of pallor or cyanosis, limpness and reduced responsiveness, and can even become unresponsive. All these symptoms actually resolve spontaneously.
Pretty scary when you're going through them though. The complex regional pain syndrome, That's actually fairly poorly understood, and it's very, very rare. It's a non-specific reaction, and they don't know, it's possibly more to the needle, the actual technicality of giving the needle, than what it is to the actual vaccine. Guillain-Barré syndrome, whoa, sorry, trigger happy. Guillain-Barré syndrome, that results in acute onset of flaccid paralysis that specifically, it's rapid and progressive and it's ascending, okay? Ascending, coming up, it's ascending. And I've just got it written here that it was associated with the influenza vaccination in 1976, but not now. It's
quite rare.
Yeah, very, very rare now. Probably the most common thing you're seeing would be vasovagal, whether it be the person that you're popping the needle into or the person that has actually bought the person you're popping the needle into. So that's your most common APHE in adult and in older children. And it's important to identify between anaphylaxis and vasovagal, because, you know, if you think somebody's having a vasovagal and you don't act on it, they may actually be having anaphylaxis. We're just about to go through the differences, but one of the things that is quite different is in a vasovagal, you've still got a strong central pulse. Okay, so if you take a central pulse, you'll be able to tell if they're having a vasovagal or not. And anaphylaxis, well, we're going to discuss that in depth in a moment.
So our signs and symptoms of vasovagal, I'm quite sure as nurse immunisers you've all experienced a vasovagal. So it's immediate, within minutes or even during the vaccine administration. You get, with your respiratory symptoms, normal breathing. You don't get that increased work of breathing at all. They might be a bit shallow, but they won't actually be laboured. Cardiovascular, so they'll be a bit bradycardic, might have a weak or even absent peripheral pulse, but that hypertension will be quite transient once they're in a supine position. And as Margie just said, they've got that strong carotid pulse.
And they tend to put themselves in a supine position without you trying. Vasovagal.
And for the skin, it's generalised pallor, cool and clammy, and they get that real feeling of being faint or lightheaded. They often give you a bit of pre-warning and get that nausea and vomiting sensation. So it is the most common APHE, and it's important to be able to tell the difference.
Absolutely. And something, you know, we'll go into it in a minute about children. So what is anaphylaxis? So it's a severe allergic reaction and the most serious APHE. We keep repeating that. It has multi-organ system involvement. Generally, the two main systems affected include your respiratory and or your cardiac, and then you've got plus or minus integumentary, so your skin, your GI2, your T, your neurological. Okay, so anaphylaxis after vaccination is rare, and it does generally occur rapidly within 15 minutes of the vaccination. And we had somebody come into where I work not so long ago because they had anaphylaxis for last time, and I was watching them like a hawk. In fact, I sat in the room with them for the first half hour and chatted away. So I thought, if you go into an anaphylaxis, then we're ready for it. And it does require immediate assessment and management.
And just something Margie's mentioned there in regards to respiratory and or cardiac, and that's something to be just mindful of if and when this actually happens.
Exactly. Now, I'll try and not go too fast here because I get a bit excited with the anaphylaxis pathophysiology and start talking a bit quick. All right. So first of all, you get your blood flow increase into the area affected by the allergen, and that leads to the inflammation. So the anaphylaxis mediators would include, of course, as we've said, the histamine response. All right, so you're going to end up with bronchoconstriction, all right, and increased airway edema. You get a smooth muscle spasm, you get pulmonary vasoconstriction. So you've already got, if you've got bronchoconstriction and increased airway edema, you've already got trouble getting your air in, you've got trouble getting your air out, okay? Then you get smooth muscle spasm. So what are you going to hear? You're going to hear a cough, okay? Then you've got pulmonary vasoconstriction, okay? So then around your lungs, you're getting vasoconstriction. So you haven't even got, so if everything's constricting, the air that's getting in is still having trouble getting across to the veins, and then it's having trouble getting out. Once though you finish with the pulmonary vasoconstriction, you go to cardiac, you've got vasodilation, okay? And that increases your problems again. So vasodilation, of course, as we all know, means the pipes are getting bigger. And once the pipes get bigger, as we know, you get that drop in your blood pressure. So they also causes increased vascular permeability. So not only are the pipes getting bigger, the pipes then start to leak. So then you get an intravascular volume loss. So you're having trouble getting the air in and out. You've got smooth muscle spasm going on and you're coughing away. And then what happens is your pipes widen, you're increasing vascular permeability, intravascular loss, bang, bang. It's not a pretty picture. And then on top of that, you get coronary vasoconstriction. So your pipes are getting larger everywhere else, but they're actually constricting around the heart, which means your heart's trying to pump and pump fast to get that lack of oxygen around the body and to actually to get it to the cells that are hypoperfused. And then your poor old heart gets this vasoconstriction happening with the coronary arteries. So, yeah, it's not a great situation to be in. And of course, with your skin, you get your increased capillary wall weakening and permeability that Steph was talking about before. And then the GIT, well, they'll again get you smooth muscle spasm and the nausea and the diarrhea, and they want to be vomiting. Some people, they don't all get all of these things, okay? Some people will only get respiratory or only get cardiac, or in the ones that you're not as worried about, they've only got the integumentary, the GIT, and the neuro. And if you get a decreased conscious state. So is anything in there, sister?
So just in regards to following on from Margie when she was talking about the blood pressure. So you actually, once you get that vasodilation happening and you're getting your drop in your blood pressure, your hypotension, you get 35% of your vascular volume can move into the extravascular space within 10 minutes.
Yeah.
So it all progresses really fast.
It does. If you get to this stage, it does start to progress really quickly if you don't start treatment. So hopefully you can see this. So upper respiratory, so you notice all in here that histamine's involved in all of them. So, and we all know histamine because we all know about antihistamines. Okay, so in the respiratory system, you're going to get a persistent cough from your bronchospasm, okay? You're going to get a wheeze as they're trying to breathe out. You're going to get a stridor as they're trying to breathe in because you've got that build-up of edema and mucus and whatnot in your airway. They're going to have dyspnea, okay? Difficulty breathing. They're going to have a hoarse voice. They're going to have hypoxia, or they potentially will have hypoxia. They get a feeling of, some people get a feeling of tightness and tingling in their throat and difficulty swallowing. So it's really important to ask them, to not just look at them and think, oh my God, what is going on? Actually ask them, what are you feeling at the moment? Tell me what you're feeling. That is just a really important assessment tool to know exactly what is going on in the areas that you can't see. As it says here, rhinorrhea, so they can get a runny nose and sneezing and angioedema, and of course we mentioned the stridor. Cardiovascular wise, of course, once your pipes widen, you get profound hypotension. Then you get tachycardia, of course, because what's your heart trying to do, even though it's got vasoconstriction and the poor little heart's trying to keep up with everything, it's trying to pump as fast as it can. So they're tachycardic. Vasodilation, we've mentioned, the increased vascular permeability, we've mentioned, all of those things add up to your hypotension. And you actually want them to be tachycardic, but if they become bradycardic, you're further down the track than you really want to be. And then, as we said before, you've got your nausea, your vomiting, your abdo pain, and your diarrhea as far as your digestive goes. And then your skin, you've got your flushing, your urticaria, your angioedema, and your itch. That's another, I really like this. So when you get your slides, just have a good look at it and, you know, just make yourselves aware of what you're looking for. You're not going to remember the pathophysiology behind it if somebody's collapsing in front of you, but you just need to know these are the signs and symptoms of anaphylaxis and this is how I'm going to deal with it.
So in severe cases of anaphylaxis, it leads to shock. This is not where we want to be. circulatory collapse. We've got our altered conscious state. They've got an impending sense of doom.
They do.
And they'll actually tell you that their anxiety levels go through the roof. Profound hypotension, like Margie was just talking about, weak or absent pulse, marked respiratory compromise, and you've got that lower airway bronchospasm. So what we've been describing is someone who is in anaphylactic shock. These are the hallmark signs, and you don't want to get to this stage before you start any sort of treatment. You've got 3 stages of shock. Your initial stage, identify it early and manage it really aggressively. Second stage, it's that, oh bugger moment. Where are we? We're at that crossroads. Is it going to go up or is it going to go down? It's dependent on our management, our treatment, and our patient response. And the third stage, we just don't want to be there. It's a slippery slide to the point of no return.
Interesting enough is some of the stats that go with it. So the risk of death increases with age, all right? It's about 7 times fold more in adults compared with children. And it's approximately 75% more in black versus white people, and a 30% increased risk in us females. So that's not ideal, but anyway, that's what it is. I don't want you to never want to give a vaccination again. So, you know, this is rare. Keep remembering it's rare.
And what we want for you is to be able to go, I remember them mentioning something about this. This is not the pathway we want to go down, and acknowledge it early and manage it early.
Exactly.
So risk factors for fatal anaphylaxis. We sound like we've been doldrums.
I know. We'll come out of the middle. We'll get some adrenaline and get us all going.
So poorly controlled asthma. So you're thinking of those airways that are already compromised. Allergies to nuts or shellfish, drugs and insect stings. Adolescents, delay in administration of adrenaline. Pre-existing cardiac and respiratory conditions.
And I think a big one, I mean, I know they all say, I know they're all there for allergies and they're all important, but delay in that administration of adrenaline is a really big one. But we'll go into that. There's a story I can tell of somebody that's given me permission to tell their story over somebody that actually had a delayed adrenaline when they wanted to have it. All right, what's important? This is what's important. Early recognition, guys. Early recognition is absolutely crucial, all right? So assess the patient immediately. So if you've got somebody, you've got to be thinking to yourself, that baby was well when it came in. That adult, they were well when they came in for their flu shot. They didn't have any signs and symptoms of anything, and suddenly they're short of breath. Something not quite right here. Suddenly they're feeling all sweaty and dizzy and a bit faint. Yeah, no, not quite right. So early recognition is absolutely crucial. So assess them and then treat. Treat.
And to assess them, we're going to use our doctor's ABCD algorithm.
Absolutely. That's something in our courses that we absolutely hone in on, is how to assess with using your doctor's ABCD. It's so important. It's back to basics and fixing things before you move on to the next step. So management, adrenaline. I can't say that enough. Unfortunately, a lot of people are, because we don't use it very often, unless you're working in an emergency field, you know, adrenaline's the last thing you want to be getting out of the cupboard and actually giving, but that is your absolute lifesaver. So I'll just go down. So the mechanism of your adrenaline is that it's a potent vasoconstrictor. So it stimulates your beta-1 adrenergic receptors. So if you remember, beta-1 is you've got one heart. This is how I've always remembered it. So that works on the cardiovascular. Beta-2, you've got 2 lungs. It works on the respiratory side of things. So, what am I trying to say? Let me read this. So it increases your vasoconstriction. It increases your peripheral vascular resistance, and therefore it's going to bring up your blood pressure, and that's what you want. It also relaxes the bronchioles. The bronchodilation, it has a bronchodilatory effect, so you end up with your bronchioles that are constricted actually opening up. And it's got what we call, it's got two big words, inotropy and chronotropy when it comes to the heart. So it increases the force and the contraction of the heart, and it increases the speed of the heart, which is what you want. And it also decreases the release of those inflammatory mediators from both the mast cells and the basophils, okay? And so that's going to decrease your angioedema and the mucus buildup and the swelling. Interesting enough, it also works on the liver, and so it turns glycogen into glucose to give you more energy so that you can, so the body can recover quickly. So it's nothing to be scared of. It does all these things. If you gave it to somebody and you weren't, they weren't in anaphylaxis, but, they had lots of signs and symptoms that made you worried that they were in anaphylaxis, and you gave them the 500 mics, which we'll go into in a minute, of adrenaline, they're going to feel crappy. They're going to feel like, and their heart rate's going to go up, and they're going to feel lousy, but you're not going to kill them. Okay, they're not going to die from you giving them some adrenaline. There we go. Missed those bits. All right. Dosages and administration.
Would you like to press the button?
Oh,
please?
sorry.
All right. So adrenaline dose. It's 1 in 1,000, or we like to try and keep it nice and simple. It's 1 milligram in 1 mil, or 100 micrograms in 0.1 of a mil. So when you're talking a child that's less than a year old and you're having to give an adrenaline to that child, it's like 0.5 of a mil to 1.
0.05.
Sorry, 0.05.
Oh,
Lordy. 0.05 to 0.1 of a mil. So they're minute, absolute minute doses. So they use the 1 in 1,000 or 1 milligram in 1 mil because it increases the safety. It's universally available. Something that's really important is that we never give it intravenously ever for anaphylaxis, and that's because it's actually associated with an increased risk of cardiac arrhythmias, myocardial ischemia, and dosing errors, mainly overdosing.
You'll put them into VF or VT if you give them a decent dose of it or you'll certainly put them into a tachycardia if they don't. I've actually seen this happen once. Very junior staff member, physician gave the order long time ago, and they gave it IV, and put the person into a quite a nasty conscious VT, which they did resolve from. But never give it never ever give it IV. It's always IM in that lateral outer thigh.
There's a couple of things about giving adrenaline early. In our experience, there's probably 2 things that people are scared of. It's giving adrenaline early, and it's using an AED, so a defibrillator. So don't be scared.
No, don't be scared.
How much do we give for an adult? It's 500 mics, as Margie said, into that lateral thigh. For an infant and pediatric dose, it's 10 mics per kilo, or as your protocol. And if you don't actually improve, every 5 minutes, we're giving it until ambulance arrives.
So when we say give it early, so we've had a patient in the past who asked us to tell her story as we go around because she doesn't want other people to have this happen to her. She was at her workplace. She'd never given herself an Epipen before. She started to have some anaphylactic signs and symptoms, and the person at her workplace actually took her pen, put it on the other side of the table and said, "You're not sick enough, you don't need that." So the workplace was probably 20 minutes from the hospital, and it took the Mica-Rambo 7 shots of 500 microgram intramuscular injections of adrenaline to actually get her airway back, to actually bring her airway back to where we wanted it to be, where she could breathe. So your airway's a little bit like, we all relate to pain. I'm not sure where we had this. We all relate to pain, If we allow somebody to get into pain up here, it takes us a lot more medication to get it down here. The airway is the same. The smaller the airway goes in diameter, the more adrenaline it's going to take to actually open that airway up, which is why it's really good to give it early. Recognize it and give it. And hopefully, you know, you'll have another nurse or somebody else with you, unless you're working in remote, a doctor or somebody there to give you a hand.
And it's actually shown that in 35% of cases, you actually need to have that repeat dose of adrenaline. So that's reasonably high.
That is, actually. So your anaphylaxis response kits, you should have the 1 in 1,000, which I hate that terminology. I always call it the 1 milligram in 1 mil, because I could just never grasp what 1 in 1,000 and 1 in 10,000 means. A milligram in a mil of adrenaline. A 1 mil syringe, you want your 23 millimeter needles for intramuscular injection for your adults. And so we said this PowerPoint last week and we didn't get to put on there, you also want your pediatric needles as well. You want to be able to put a record of the doses required for administration, and you want your protocol. So what happens is that, oh, sorry.
Yeah.
Go.
Sorry, I was just going to say something. We do this to each other all the time. So when you're doing your drugs, especially for pediatrics, there's two things we want you to do. If you can, of course, if there's more than one staff member, take that 10 seconds, 20 seconds, 30 seconds to actually separate and work out your dose separately, come together. It's your fail safe. That way, I know we've all got our cheat sheets on top of our kits, but it's just important to know that you're on the same page. And the other little fail safe for adrenaline too is if you're giving a dose to a kiddie, like it's 0.5 ml for an adult, so 0.5 of a ml, 500 micrograms. If you're going to give a 3-year-old, you've drawn up your adrenaline, you've looked at it and you've got 500 mics there, that's a flag to go, I've not quite got this right. It's a highly stressful situation to be in, and errors do happen. But if you just take that half a second before you give it, have a quick glance at it. If it's sitting up at that 0.5, take it away and recheck.
Now, I don't know, I'm assuming that you guys have all got, can you see that? Hopefully you can see that. I know it's backwards, but it's basically the ages, the approximate weights, and exactly how much to give in mils. So, you know, if you're doing resus stuff, okay. So, you know, in resus stuff, we work it out as 10 micrograms per kilogram, but you don't even need to do that. It's just written there in point mils. And it has happened before where mistakes have happened because people work out the drug calculations together, or they go over there and go, yes, let's do this together, rather than making sure you do it separate, as Steph just said. I can't say that enough, and then come together, okay? So with anaphylaxis also, we get adrenaline, you can get what we call a rebound effect. All right, so if the person has reacted to the adrenaline and their anaphylaxis has settled and they're breathing again beautifully after the first dose, that's brilliant. They probably only need 4 hours in a hospital. They all must go to ED. They just have to go to ED for observation. If it's taken 2 lots of adrenaline, okay, then they should be admitted overnight. I mean, that's obviously not your worry and not your call, but just so that you know, your patient will probably be admitted overnight for observation, because they can have that rebound effect hours later. They can suddenly get the anaphylaxis back again.
And that young person that Margie gave you as an example was admitted to hospital and rebounded for 5 days. So it might not just be the 24 hours, it can be ongoing. Right, so
7:20.
You want to click?
Yes, clicking.
Thank you. Okay, Epipens. Some of us have these in our top drawer just as a bit of safety. We'll just do a quick refresher. I want you to grasp the Epipen like it's a stubby or a can of beer.
Or a glass of wine.
Or a glass of wine, depends on what you like. So always looking for your safety. Never put any part of your hand at the orange end. The orange is where it goes to your thigh, so orange to the thigh, blue to the sky. and the orange is where the needle comes out. So they're adrenaline auto-injectors. They've got doses for adults of 300 mics, so it is actually a little bit less than what we draw up, and pediatrics 150 micrograms. Bit of conjecture on who you look at. The Australian Immunisation Handbook says children over 10 kilo. The ASCIA, who is the Australian Society of Clinical Immunology and Allergy, say that these EpiPens can be used for anyone over 7.5 kilos.
Okay, beautiful. And do definitely grasp that, because it did happen, not in an area that I know of, but it has happened where somebody's put their thumb on the top to give it like that, which we all automatically want to do, and they got the needle, so they got the adrenaline, the child died. So yeah, always just grasp it.
And that little blue cap actually flicks out. That's your safety catch.
It is. And then there are one use only. All right, anaphylactic shock priorities. Give adrenaline, okay, and lay them flat. That was something else that we actually wrote on here afterwards. So give your adrenaline, sit them down or lay them down. If they start running around because they're becoming hypoxic, they're then going to push that antigen further around the body, okay? And the more that it goes around the body, the sicker they're going to get. And that also happened to a friend of mine's niece. So she was just very lucky. The ambos were in the ambulance bay a minute up the road. So they couldn't catch her. She was so young, and of course she's hypoxic, so she's just going nuts and running around the house. And ended up very, very sick. So sit them down, lay them down preferably, give that adrenaline into the outer thigh, apply the oxygen, then call your ambulance. Of course, if you've got other mates there working with you, call out to one of them to get that ambulance on its way. Do a set of vital signs. You know, you don't really want to know how hypotensive they are, but it is actually quite handy. Pardon me. And then if you've got somebody that can put in a cannula, put in a cannula and give them some fluids. For the adults, we tend to, of course, you'll have doctors there to give you the orders, hopefully, otherwise somebody over the phone. For an adult, we tend to bung in a litre of normal saline. For the kids, we tend to do 10 mils per kilo, okay? Because you've got to remember they've got that profound hypotension because the pipes they're still vasodilated. We need those pipes to come back to vasoconstrict for that to actually happen. If you've got nothing else better to do an ECG, but that is the absolute least of your priorities. And if you don't get there, it just doesn't matter.
Sometimes people think that, you know, it's a bit of asthma, so we'll give the asthma puffer. Don't start with the asthma. Give your adrenaline first. You can then, if you want to use a bronchodilator in between, if you're having to do multiple doses, you can do that. And certainly antihistamines are not your first line of treatment in regards to anaphylaxis. And the Ventolin cannot take the place of adrenaline. If you're doing it as an adjunct, okay, that's all right, but it cannot take the place of the adrenaline because it has a completely different action and it will not save their lives. Adrenaline is your best friend. And the glucocorticosteroids, I've just got these in here because these are a lot of things that people ask us. They ask us about bronchodilators. They'll ask us about the antihistamines. Forget the antihistamines if they're in anaphylaxis. Give them the antihistamine if they've just got a little bit of lip swelling and, you know, a little bit of urticaria, you know, they're in a mild, definitely. We give loratadine 10 milligrams generally. The glucocorticosteroids. So, you know, 15 years ago, you'd run to the drug cupboard and you'd get the hydrocort. You get the line in and you get the hydrocort in and you'd stand there and hope, you know, and you didn't want to give that adrenaline for love nor money. But these days, there's a real push to give it early. Okay, now, before we go there, are there any questions? Alicia, do you want to take control of that?
I don't have any in the chat box at the moment, but if anyone would like to unmute themselves and ask a question, I'm more than happy for that to occur.
Lovely, thank you. So guys, what we're going to do now, Alicia, the clever Alicia is going to put you into chat rooms. So there you'll be able to do a little bit of networking there and have a chat. And we've got this case study.
So we've got 18-month-old Anna Anaphylaxis, who's presented with her mum.
Very lame name.
We love it.
Very lame.
With her mum for her immunisation. Mum said she's not had any problems and she's quite well. So you give her a routine Proquad Actib and Infinrex, and 5 minutes later you hear mum. She screams that Anna's just not quite right. You come around the corner, this child is flaccid, pale and unresponsive. So in your Zoom room, just have one person as your representative to come back to us and we'll present what you think. What we want to know is what is your assessment of this child and how you're going to manage her.
And what are your red flags? Okay, so go and have a chat. We'll just do 5 minutes because we're running out of time anyway, and then come back and we'll get one person to say what you've come up with, and then everyone else, the other guys can come in if they have some other information that they'd like to add. Okay, go for it, Alicia. All right,
So
ladies.
what did we come up with?
Yes, let's go to group, since we ended up in group 2, we're going to let them off the hook. So let's go to group 1. Who was in group 1?
No one?
Okay, let's go group 4.
Well, Linda, were we in group 1?
No, you were in group 2
Oh,
with
okay.
me.
I thought we were in
We
group
don't
four,
know. We
actually.
don't know what our group
you
numbers
get
were.
to speak.
Okay.
Wait, hang on.
Oh,
You
okay.
don't know
Well, in
that,
that
right?
case, okay. If you didn't know what your group numbers were, that's no problem.
We're in
Somebody
three
just start telling us what they thought.
So what were you, anyone tell us, what was your initial thought of
How come we can't
this
hear
little
them?
child that's
Can you
walked
hear
in,
them? Can you put
given
volume?
your vaccine,
Is it coming from
and then
No.
next thing you've got a flaccid, pale, unresponsive child. What's your first thoughts?
Okay, we were super proactive. We thought it was anaphylaxis and we didn't care if it was anything else, and we jabbed in that adrenaline.
And how much did you
0.1.
give? Oh,
0.1, and we set our alarm and we were ready for the next 5 minutes because we didn't have any oxygen, we didn't have any drip, and we called the ambulance and we
Good
reassured
job.
the mum.
beautiful,
Excellent.
beautiful. And
Yeah.
that's exactly what we do. Something we didn't mention before
Yeah,
is,
which I need to. I don't know how I
well,
missed
there's
it.
2 things. You can say your thing, but mine was just in regards to, we're talking about giving adrenaline, oxygen and how important it is, but please do remember your COVID considerations too at this
Actually,
point in
that's a good
time.
point. And the other thing that I wanted to mention was that if you've got a pale flappy, you might be the one that's flappy. If you've got a pale floppy child, then you've got to think hypotension. If they're unresponsive, you've got to absolutely think hypotension. Okay, that is the hallmark sort of look of a child that hasn't got much blood pressure. I was saying to the girls, do a cap refill. If you don't do a set of vital signs, but when you're doing that initial assessment, when it comes to C, do a cap refill. 5 seconds, count it out. If that's longer than your 3 seconds, you've got a sick child and you need to give them some fluids and give them some adrenaline. Gosh, and then some fluids. Now, who else wants to say something? Oh my goodness, we've got lots of things. Not sure of my group. Check. Jamie. Limp, clammy, nauseated, pulse, draw up the adrenaline. Well done, Jamie. Absolutely. Does anyone else have anything to say?
We have someone from group 9. We had 2 Jennies and a Lisa.
Great.
Any
How did
further?
group 9 go?
No, some of the groups may have had some technical difficulties. It looked like they
That's
did
okay.
I'm going to do a meeting. How about out now? Quick.
Something we did mention in our group too is when you're doing your assessment, so you're going through your doctor's A, B, C, D, you've done your danger, you know what's going on, you've got your response, you've got your team there, you're getting some help, and your A, B, C and your D are all done within about 15-20 seconds. So you're checking your airway. You can either hear or see a sound. Oh, sorry, you can't see a sound, can you? But you can hear a sound, or it's a clear airway. you're looking at the breathing as you're looking at the child. You're watching the rise and fall of the chest, or is it not at all, or is it limited? Then you see, as Margie said, do your central perfusion. 1, 2, 3, release. Oh, mine's nice and brisk. That's good. And you'll know how well perfused your child is, and then your disability. So with this child, was unconscious and flaccid. So we know that we're in a world of pain. So well done for.
Yeah, good job, guys. Good job. That's something we do at our courses. We do what we call our A to G of MIE, which is going through exactly how to assess, how to assess and get yourself really quickly to that situation of saying, right, I'm giving this adrenaline. It's going to happen. So, does anyone else want to say something? Or does anyone? No.
We were a little bit slower. We were going to ask the mum what exactly is going on. So
okay,
probably lost a child then.
No, you wouldn't have.
Not at all.
Because
love it.
Because what happens when you've got this well child and you've walked them in, or you've been interacting with them in the 10 minutes prior to your immunisation, you've got that little bit of a rapport. So you've already you already know that this child was well.
And mum's going to react pretty quick, so you actually wouldn't have lost a child. She'd have said, this is not normal, and you'd have been off and running.
Can I ask a question?
Yes, please.
Well, I read somewhere that with any anaphylaxis patient that we treated and they recover, we still have to admit them to hospital overnight. Is that right?
So they're the ones that if they recover from the first lot of adrenaline, generally we'll keep them for 4 hours, and if they haven't had any further signs and symptoms, they can, often will go home. But if it's taken 2 lots of adrenaline, and that's 35% of people that need 2 lots of adrenaline, then they do definitely need to be admitted. But every single person that you have to give adrenaline to must present to that emergency department closest to you.
And that's with an ambulance. That's not going in private car.
Not private car.
Thank you. Yeah.
If they rebound, you'd want them in an ambulance so they can have more adrenaline.
Okay, thank you.
Yeah. Any other questions?
So adrenaline is a vasoconstrictor, but a bronchoconstrictor as well. Well, wouldn't you want a broncho?
No, it's a bronchodilator.
Oh, okay.
Yeah. So it's when we say it's a vasoconstrictor, it'll bring those pipes back in. Okay, but it actually, so that's the beta 1 effect. So that's the beta 1 effect. The beta 2 effect works on the respiratory system, where it actually dilates, opens up your bronchioles, and actually decreases that mucus production, which is a beautiful thing because that's what you're after.
And it actually works quite quickly when you do give it. So it's a very nice feeling when you see it.
If the baby weighs 4 kilos, is it still 40 micrograms, 0.4 of a mil, or is there a minimum of the dose? 4 kilos. No. Okay. So, yep, 40 mics, so 0.04 of a mil. Look, you can get that fussy, absolutely, and we do with kids under the age of 1. And but this what a lot of you have, someone could spotlight that, what a lot of you have in your clinics where it's actually got it for under the age of 1, they'll give 0.05 to 0.01. But that's for 5 to 10 kilos. It's a good question. If I was there, I would go 10 mics per kilo, but you guys need to go on whatever your protocol actually says to make it simple. Does that answer that, Heather?
Working in council or in outreach. Have no OT and drip. Have to be confident in adrenaline.
Yes.
Absolutely.
Tracy, you're spot on. Yep, when you're working in outreach and you're working in, even if you're working in doing some outback, Northern Territory, WA work, whatever, you need to be confident that you can give that adrenaline for sure. And that's a really good point, Tracy, a really good point. So just, you know, if you're worried, if you've got any, just remember, if you've got anything respiratory, anything cardiac, and a little bit of the, you know, maybe some of the other things going on as well, integumentary, GRT, and neuro, give that adrenaline. Okay. Had a preemie that weighed 3 kilos at 6 weeks. Heather, did that child have anaphylaxis?
No, they didn't, but I just wondered, because it said before the minimum amount, and I just thought, would that be too much to give, you know, the minimum recommended dose?
So the minimum that we were talking about before too was for the Epipen?
Yeah.
Yeah. So,
yeah, 150. That's
yes.
for the 7.5.
Yeah, that's for over
age.
7.5 kilos. Yeah.
Yeah.
It's not recommended for EpiPens under that age and size.
Your little ones under 4 kilos, I mean, you know, talk to your medical people about this, but I would be tempted to give them your 0.04, what you said before.
Yeah, so just go slightly higher.
Yeah, 0.05 wouldn't harm them, but I probably wouldn't go to the 0.1. I think that would be a bit more than what they need. But again, it's a little bit like defibrillating. They're better to get some joules than no joules. Do you know what I mean? Like, they're better with defibrillation. You know, if you've only got adult pads and you've got a child, you're better to put child pads on and give them an adult dose than to give them nothing. So it's a little bit the same with this, because their little airways close over those babies very quickly. Thankfully, touch wood, haven't had a little one that size that's actually had any sort of anaphylaxis.
Yeah. Are preemies more likely to get anything, or it makes no difference?
I actually don't know the answer to that. I think they'd be less likely if they're being breastfed by mum and got her antibodies. So
okay.
Yeah, but that's me just thinking off the bat. That's not with any form of research knowledge to that question.
And additional to that too, anaphylaxis occurs because of that secondary exposure as well.
It certainly does. So, yeah. Any other questions can we help with? Can we please have, if they ask or need a current list, Children's Hospital? Yeah, Children's Hospital. Who's saying that? Alicia. Great. Yes. Royal Children's Hospital website, guys. You know, we're not in the middle of nowhere. We're in Sale Hospital, and if we get a sick child in, we go straight to the Royal Children's Hospital guidelines, and we get them up and we follow them. So same in your clinics. If you know, and if your doctors are not experienced, you know, in this area and it's happening, get someone to get up those Royal Children's guidelines, and they will. And the other one, the other fantastic guidelines are with Safer Care Victoria. They've got brilliant guidelines as well. So when it comes to making your kits up, get the guidelines from there. Okay.
And the Australian Immunisation Handbook has the guide for the kits as well. I think probably most of us would have that in our clinics.
Yeah. And are we out of time, young Alicia? Oh God, it's 10 to 8. I mean, golly, it's 10 to 8. Sorry, we've gone way over time.
No, that's okay. There were still questions, so I thought let's keep going. So
okay.
I've got final questions.
Any other questions? You know where to find us. And if you just want to, even if you've got any questions and you just want to flick us an email,
feel free.
Yeah, feel free to flick us an email, and then we can certainly answer you. Just on that, you're going to get these slides. So just on that first slide, our email address is on there. So feel free to ask us anything. And hopefully we'll see some of you around as we're travelling our little Annies around Gippsland. I see Margaret up there. You're coming on Saturday, aren't you?
Look forward to it.
We will. Okay.
Thanks, everybody.
Thank you, everyone.